Assalamu alaikum. Well, I know we are a little bit late on this time, but I'm sure we will catch up as we go along. I'm Javed Ashraf, one of the cardiologists here at the Shalimar. I have two of my co-presenters here, Dr. Salman and Dr. Khalid. And we're trying to cover another important topic over next 45 minutes, I hope so. And please keep in mind, this is not kind of a lecture. It's going to be an interactive session. And we're going to concentrate mainly on the cases rather than something else. And as we go along the cases, please feel free to jump into with your suggestion, with your comments as we move on with this suggestion, with the cases. The topic is very important nowadays. So I want to show you a couple of slides, introductory slides, in terms of what the background about this and what we should be doing and what we are actually doing. So it's always been a question, is the provisional one-stent strategy versus two-stent strategy? And we also will talk about, in the same provisional one-stent strategy, another technique, which Salman will going to talk a little bit more about that, and that JSKBT, using the balloon of the side branch and how to protect the side branch. And hopefully it will be a... So the always question is, we know that a lot of coronary interventions involve the bifurcation, more than 20% of total what we do nowadays. What is the best approach? What is the best techniques? It's always been debated. One technique and one approach might be good for me compared to you guys. So it's always a different, and we know there's no right or wrong answer here, but we have some data, and we will go along. This is kind of an interesting thing. So I'm going to share you what the actual thought process, because there is so much variation in this approach that even, so this is, we're talking about the cardiovascular, this is a European journal in October 22. What they are saying is, their conclusion on one big study, that the provisional stenting with, provisional with the two-stent strategy associated with a higher rate of 3-year total lesion failure, mainly due to increased TVR. And what they are saying, so, a side branch pre-treatment should be avoided for simple bifurcation lesions. So they're talking about the two-stent strategy upfront is not a probably good approach. However, we're talking about this in October 22, last year. And this, a month earlier, at the Journal from the Sky in the States, what we see is they're talking about totally opposite. They're talking about in the era of the new generation DES, a two-stent upfront strategy is superior to the provisional stent technique for the bifurcation lesion with a significant reduction in the MACE, TVMI, and TVR. So look at that. Now what's going on across the world? I'm sure here in Pakistan, we have a different experience as well. I moved back from state 4 years ago, and I'm seeing here in Pakistan, we are seeing a lot of more, we're not using the new generation DES stent. So in our situation is way different. So probably we are concentrating on kind of this year, more on this one, because this is a big meta-analysis which was published here, and I think we're going to concentrate more here, and that's what I feel it. Okay, whether I'm right or wrong, but as I said, this field, this era is still in the developing state, and we don't know what's going to happen over the next 5-10 years. So what we're going to do here over the next 30 minutes, so we're going to talk about more of the provisional one-stent strategy. As I said, probably for most of us is a better approach. If you guys have a different concept, different thinking, please jump into and feel free to comment. And then they say among the two, if you're using the two upfront techniques, guys, as expected. Okay, so if you're using a two-stent approach up front, then likely the decay crash technique is appear to be better. And you guys just learned in the previous session the technique of this. So we're not going to talk more about that. With this, I'm going to, we have a lot of other, the basic steps which we're going to, which should be involved in the provisional techniques. We all know these things. We will talk more of these during our cases. The couple of things I would point out here, that when you have a failed provisional stent, so please be prepared at the time. One should be in our mind is that we need to know what are the bailout strategies, but just if you have failed your provisional stenting, the side branch is gone, please do not jump into immediately with a second stent. Think about a lot of other steps which include all of this use of a meticulous use of the nitroglycerine, repeat part, a side bunch rewiring and open up the strand, see if you have a flow there, and then you can do a refart again. So there are different steps which you can do it before jumping into a kind of a thinking of getting the pulling of the second stand and jumping to the second. And the most important of other ones are, we will talk about these during our cases. We all know this cartoon, we have gone through this. I think what I would like to do here, yes, this is kind of these few things which we all should be remembering every time we're going to do whenever we're going to the angioplasty, where we have we're starting with the provisional one stenting, or maybe ended up into the two stenting later on. But I think we have to, all these should be in our mind. We at least have to be familiar, very, very comfortable with at least one technique of two stenting technique, and at least one bailout technique as well. If you're not comfortable, please don't even think about the two stent strategy at the time. And we know all these steps very well, and I'm not going into those ones. And the same thing again, I would like to add here that in Pakistan, compared to in US, we have a lot of other issues in our cases in the cath lab, including we have financial restrictions, we have equipment restrictions, we have what you call the availability of the staff and the time. So a lot of things we are kind of constrained on many things. So keep those things in your mind whenever you're going to play with this kind of the cases. With that, I think we probably will come back onto the summary of the things later, and on some of those techniques, but can we go to the second the slides, please, the cases? No, the video ones, please. So we have a number of cases. So the aim of showing those cases to you guys, get your opinion what we're going to think about, and especially I'm going to jump from the people in the training right now. The kind of we all learning process, I know that, but someone who feels that they have to make a decision. Okay, so it's kind of a very simple case here. We can see there's a lesion up there in the LAD. This is kind of the acute ACS case, and the question is provisional versus a dual upfront strategy. That's the question. Anybody?
Achha, so, Javed bhai, I'm just going to make a comment here. If you go back one time. So this is supposed to be interactive. So I can tell you that Javed bhai actually has done a great job. Like, मेरी slide तब तक नहीं चलेगी जब तक कोई बोलेगा नहीं. So you have to ask questions. ठीक है, हर slide के बाद someone has to make a comment ताकि we can move forward with that. नहीं तो इस side it's not interactive. This is supposed to be tutorial. I do have a question for Javed bhai. उन्होंने कहा था कि the European जो थी recommendation में थी कि for simple lesions provisional should be approached. So I just wanted you to take a few minutes to define कि simple bifurcation क्या होती है, and is this a simple one or not? Because to my eye this seems a little bit more complex. I'll give you my opinion बाद में. So Javed bhai, can you tell us what is simple bifurcation, and how would you classify this bifurcation?
This class, we're talking about this case?
In this case, if you go back once, आपने कहा था ना कि जो European guidelines थी पिछले उसमें आया था कि for simple lesions provision should be preferred. So how would you classify this?
So we're going to classify here this Medina. We have the main vessel lesion and then we have an osteal lesion in the branch, significant lesion. So that will, well, in the European data that I showed you that one, the problem in that data was, I actually didn't go into detail, there was less than 30% of the cases had a second generation of the stents used in that case. So that is the problem, and it's actually not a problem. That's a real practice.
Right.
Okay.
Yeah.
Which kind of fits to our situation in Pakistan. And what is in the Sky one, which published in the Sky journal last year, they had a majority of the cases in that meta-analysis are from the. Yeah, I think I'm okay with here. Or all the TLVR, all those things are higher in the first generation and the old generation. So that was the main. Okay. So I'm going back here now with this kind of simple case here.
What are the predictors of the occlusion of the side branch? कौन से फैक्टर होता है जब हमें अंदाज़ा होता है प्रोविजन स्ट्रेटिंग करेंगे तो साइड ब्रांच बंद हो जाएंगे? कोई प्रिडिक्टर्स होते हैं जहन में? एनी पोस्ट डेफिनेशन या रिस्क फैक्टर बता दें कौन से होते हैं?
The actual bifurcation probably is not having disease at the ostium of the diagonal. There is disease below and above that. But can we cover it with 2 stents? I think the answer is no, because we have to put a stent across. And then there is disease which probably extends more than around 5 to 10 mm in the diagonal. Probably this will be more obvious in aleocranial. And the other thing I would like that if this picture this has horizontally it's quite long, so there is no symmetry in the picture, so if these can be adjusted properly so that one can be more properly comment on. So there is more of on the, so this is.
Actually the degree of the stenosis, the osteobranch stenosis of the side branch, once plaque burden, third calcification, so diffuse disease, decreased tipping flow in the side branch already, ACS patient is a strong predictor of the total occlusion of the side branch. Okay, one apply the major and minor criteria in the before the presentation is mentioned. Thus, first thing in the length of the side branch lesion more than 10. If the life main, the side branch lesion is the lesion more than 90%. In the non-left main cases, if the lesion here is more than 90%, so it is a major criteria either fill. Okay.
Yes, I intentionally did not put the banana classification up on there. We all know that this is going, we all know what exactly is criteria for that. My intention did not put that up on the slide. So the question was that in this case, yes, obviously as Dr. Khalid said that we have to consider those criteria whether the need for me to protect the second branch or not. To be very honest, I know we all know the Medina Classic, but in the real practice, sometimes we think one other very important criteria, which is how much is the territory of that vessel supply. I know we talk about the size more than 2 millimeter, 2.5 millimeter, or 2.3 millimeter on the side branch, and how the osteal is 90% or 80% before we pre-dilate or where we think that. But I think one other big message is, and we all know that, we all do it, and that is how much the territory involved into that. And sometimes when you look into the territory, you have to go from multiple what you call the views to know what is the, sometimes like this diagonal branch, probably not that high, that big on this view, but if you go to the epicranial view, you might see it's covering the whole lateral side of your myocardium. So that is a very key important here. So in this case, the question was that should we wire this? The answer was very simple. It's a tight lesion, and the wire was placed in. The decision was made for the provisional rather than the bifurcation upfront two-stent strategy. And the question was that the next question comes up: should we pre-dilate the ostium or not? So there is would you like to have some comment on that? Which cases we should pre-dilate the ostium of the side branch?
नहीं अब उसमें तो I've got so many comments, लेकिन I also want कि आपका case हो सके, हम और cases भी दिखा सकें. But the bottom line is this: absolutely, you've got to assess the distribution, the relative distribution. You also have to assess the health of the ostium. जैसे आपने जिक्र किया, the health of the ostium of the side branch. Obviously, America में we have other opportunities. हम लोग FFR कर सकते हैं, हम लोग IVUS कर सकते हैं. लेकिन एक जो बात जो प्रोविजनल के हक में जाती है वो ये है कि अगर आप एक लो प्रोफाइल बलून लेके उसे प्रोटेक्ट कर लें तो maybe you can avoid a second stent. So maybe it's significant, maybe it is not significant, but if you use a provisional approach, you may be able to get away with one stent.
So you're saying the second balloon, like you're going to talk about that, the putting the balloon and keeping in the second one.
Absolutely.
Yeah, Salman is going to talk about that, another technique, which is where putting your balloon into the ostium and the proximal part of the side branch. However, a lot of people don't use that. It is said that if you have an ostial which is calcified, which is like an 80-90% stenosis osteum, and if there's angulation and if there's a calcification of the side branch, immediately at the osteum or immediately after the osteum, think about the pre-dilatation of those ones, of the balloon, before putting your stent. So exactly that's the thing we did in this case. The osteum looked like a pretty bad on the side branch, and I hope it will play now. Okay.
Can you have the next slide?
I'm
Slide
going to
आगे
next.
करते हैं.
Okay, so the balloon was, the osteum was balloon on this as well, and because we thought okay, the osteum is pretty bad, it's 90+%. And the reason they're saying that the chances of protecting the branch is higher if you pre-dilate those balloons. I'm not talking about the technique which Salman is going to talk about, keeping the balloon in the side branch. We'll talk about a little bit later that. And then we put this long stent there. And I want to show you here, that's the result. Okay, so the question is it optimum result? But this is the one thing I think we all need to know, that because a lot of time we don't feel comfortable. So there's a lot of thinking process. As I said at the beginning, there's no right or wrong in this, the discussion we're having today. So is this an optimum result or not?
So I would say कि it is. उसकी वजह ये है कि जो साइड ब्रांच है उसमें फ्लो उतना ही है जितना पहले था. So as long as the side branch does not get worse and the TIMI flow does not go down, it's good, right? So you've got TIMI 3 flow और वही जितना 70% जितना भी narrowing थी उतनी ही है. The only thing is कि the main branch stent could be a little post dilated, but
Yes,
वो अलग बात है. But
right.
that's a whole separate question. But as far as the bifurcation is concerned, I think this would be a very acceptable provisional result.
Right, it's exactly, we actually did the post-stent dilatation of the proximal branch, of the main branch, we did that. But I think, yes, we always think about, oh, ये तो भी बहुत बुरा लग रहा है. हाँ, ये तो भी 90% लग रहा है, 80% लग रहा है. But the important here is, we have a very good flow, we have a TIMI 3 flow. It's the same. So I would not mess up here. And especially the cases we see in our population. So as I said at the beginning, my experience from the America and Pakistan is so different here. We have a diffuse disease. Most of our cases are way, way different, Salman, compared to what I used to see in States. So diffuse disease and all those things, I would be very happy with this. Man Hashmi see a lot of these cases every day as well. Any comment from your side, sir?
I think the main confounder is what is the diameter of the side branch and how much of the myocardium is supplied by the side branch. It's not the cosmetic reason that we want to see the side branch open and having a no osteal pinch or something like that. But if the side branch is less than 2 mm of diameter, then it's quite good if we have a TIMI 3 flow at the end of the procedure. If you have 90% stenosis, 95% stenosis, it doesn't matter. But if the side branch is less than 2 mm of diameter and is like 2 or 3% of the myocardium is supplied by that side branch, and there is the TIMI 3 flow in the side branch, I think that's good enough to.
Actually,
One word, cosmetics, exactly. We should not be going for the cosmetics here. No, I think this is totally against we ended up in a trouble rather than making it look good. Okay, so Dr. Khalid Sahab, aap kuch karein.
actually patient have no chest pain, no ECG changing,
Yes.
and similar result of this one I think is an no cosmetic result.
25% EF and this big branch, it becomes important as compared to somebody with a normal EF and this big branch. So this, I totally agree.
Again, उसमें भी हमारे थॉट्स बदल रही ना, तो कि coronary disease सारी फिक्स करने से इसकी में कार्डियोमायोपैथी रिवर्स होगी कि नहीं? I think the answer is probably not. So आपकी बात सही है कि अगर if it's a left main, तो अगर left main पे circumflex इतनी tight है, you don't want to walk away from that क्योंकि वो inflow disease है. लेकिन जहाँ पे side branches आ जाती है, even though the EF may be low, I think it's worse. दूसरी थी कि to be honest, पाकिस्तान की considerations और हैं ना, एक तो consideration ये है यहाँ पे कि you have cost considerations that patient pays. So this is still a better thing because side branch is still looking good and the cost is acceptable.
After stenting it or just leave it?
Well, the wire, we will only put the wire. इसके बाद फिर मैं आपको छोड़ूंगा, इसके बाद Well, if I'm going to put the rewire, if I have an intention to either dilate it or like in a kissing balloon, something like that. Keep in mind, if we are going to rewire the side branch, and if you're going to use the balloon, we have to end up doing a kissing balloon. That is the kind of must then.
I totally agree. I would keep it simple.
Yes.
Do not wire it.
Did you guys understand what we're saying to the, if we're going to put rewire the side branch and we're going to use the balloon in the side branch, we're going to disrupt these stents. So we have to, it's going to be a mandatory at that point that we end up having a kissing balloon all the time. And the things will go more complicated. I think the cosmetic reason that Hashmi exactly said right. And to be honest, we all kind of seem agreeing on that. Okay. Just another quick one. I'm not going to detail on this one. This the gentleman, relatively younger, 53-year-old guy, comes up with the ACS and have it this. His right is significantly diseased, diffusely diseased, not a good target for the bypass, and he refused the bypass. Okay, so what are we? Another thing there now, keep in mind, we see a lot of more Pakistan ke andar na, Salman just changed you. I see a lot of refusal from the patients and family point of view. We have different perceptions, different things, and the things are not exactly the same as I used to see in the state or you see over there. People go for shopping in the different places and they ended up coming back to. So this is the case now. So what would be what we're seeing here now? So left domain is not no major disease in the left domain, and what we're seeing in the osteal LAD, okay, significant osteal LAD, okay, and the circumflex, we have a proximal significant disease, but not as bad. So what is the thought process here? Pardon? Left domain to LAD, so we're going to with the 2 stent upfront strategy, right? Is that what we plan, or
one stent from left main to LAD and protect the left circumflex with wire plus minus balloon or something?
Okay. Any other thoughts here now?
So again, going to आपने बात की तो about keeping it simple. तो यहाँ पे if you look at the circumflex, ठीक है, if you do IVS तो आपको पता है कि there's plaque extending from the left main to the circumflex. ठीक है, अब उसमें कि it's all the eyes of the kind of beauty is in the eyes of the beholder. तो stenosis is also in the eyes of the beholder. कि आपका अपना रुझान क्या है, अगर आपका रुझान 2 स्टेंट की तरफ है तो आप 2 स्टेंट डालेंगे, अगर 1 स्टेंट की तरफ है तो 1 स्टेंट डालेंगे. लेकिन I think यहाँ पे physiology can help. Obviously यहाँ पे FFR is an extra expense. I favor the idea, again I don't know the age of this patient.
58-year-old.
58-year-old. I feel
53 actually.
It is reasonable to do the left main to LAD because even though there's disease in the circumflex is not obstructive, and later on in life if he needs another stent, you can always come back and treat the ostial of the circumflex. So I would probably favor for cost and for convenience and for safety, maybe single stent from left main to LAD with just protection.
Okay, so here's the one thing I didn't tell you. His left circumflex was co-dominant. And it's a lot of territory in that one involved. And it's a co-dominant, and the RC is kind of a diffusely disease and the co-dominant medium-sized vessel. Yes, sir. Is FFR of the circumflex?
If you stent it, jail the circumflex, shifting of the carina and then plaque, and then do the FFR again. If that is negative, yes, you can leave it.
Okay. So, yes, that's true. So, how much FFR cost here in Pakistan? A little bit more, sir. Sir जी, आपके NICVD में सर जी हर चीज़ फ्री है ना, रोड़ा है क्या उठे? Okay. हाँ जी, आप क्या कितने का FFR होता है हमारे? 1 लाख से ज़्यादा है जी, जो से अच्छा, I'm just saying that these things are really important, Salman, here. Okay, so I think in this case, here's the thing now, that's another view now. So look at that, how big is the circumflex territory. So, we plan for upfront 2-stent strategy here. We plan for upfront 2-stent strategy here. And the reason for that, as I said, we felt that the circumflex disease was there and there were the likely chances of That's again, I might be wrong, but that was the thought process we did that in this case. And we planned this way, and I will just show you because for the sake of time, we did all that routine stuff, and I'm not going to technique on that, and we will, I'll just kind of show you the, and the final result. And I think we had a decent result at the end. And we planned in this case on the basis of two things. A, I know the circumflex was not that badly diseased, but it was a codominant, and the RCA, it was, I should have shown you in the here, it was a small vessel, medium-sized vessel, and it was diffusely diseased. So we thought that thought process was that time that if we're going to jail that one, we're going to lose a lot of territory on the sideline. So that was the thought process, and there was a lot of calcium there. So we went upfront a two-stent strategy in this case. Okay, in this case, yes, so we did that from the, we did the first the left lumen and to LED at the end, yes.
That was also an excellent approach, because I think the operator wanted to be more secure about the circumflex, because if he's not going to use FFR or IVS, so then putting in another stent might be more, easier approach and more secure. So I think
that's absolutely fine. But that's a good point. Like, I will say the same thing. Even in the States with FFR and IVS, I would have done single stent. Uski wajah ye hai ki because I think medical therapy ke saath you can stabilize disease, right? So yahan pe, I'm not saying this is wrong. I'm just saying कि there's a different state of sort of a different style of doing things. क्योंकि मेरा ये होता है कि patient can always come back. क्योंकि वो इतनी छोटी branch नहीं थी कि वो आज छोड़ दी तो कल वापस नहीं आ सकेंगे. As long as you had good TIMI3 flow, there was moderate disease even afterwards, you can try medical therapy, because you also have to see कि patient की reliability क्या है, can they afford the Plavix, can they take the medications. Anyway, so like I said, my slides will only move अगर slides के बाद comment होगा. So I don't care who says what, even though किसी जी आपकी दाढ़ी बड़ी अच्छी लग रही है, that's fine, but you have to make a comment ताकि I can move on. अच्छा, provisional stenting. So the reason to do this, the whole reason I came to Pakistan, मैं आपको बता दूँ, is for this type of thing, interactive session. मेरी बशीर से ये था कि I want to interact and meet people so they can ask me questions and I can ask them questions क्योंकि इससे मैं सीखता हूँ. So I'm doing this for myself, but I'm also doing it for you. So इसलिए if you have any questions, ask and then we'll go from there. But I believe कि provisional stenting is the need of the moment, because पाकिस्तान में बहुत disease है, not everyone is a surgical candidate, जो candidate हैं भी वो surgery कराना नहीं चाहते, so बाकी रह दे के आपके ले दे के आपके रह जाते हैं stents. A stent की cost इतनी है कि you have to come up with a way you can minimize the stent cost ताकि patient को maximum benefit हो सके कम से कम stents में. So that is the philosophy. At least that is right. So exactly. So कई वजूहात हो जाती हैं कि you want to minimize your usage of stents. Okay. All right. Provisional stenting. So 63-year-old man with coronary artery disease, progressive angina, large infralateral ischemia, remote history of an MI, which I think may be an anterior wall. Anterior wall में उनके stent है. He's got an LED stent, and he had some 45 to 50 degrees. 45 to 50% ejection fraction था. Posterior wall hypokinesis. He had some mild degree of heart failure. They actually adjusted his heart failure medications. Then they sent him for a stress test. तो इससे आया था infralateral ischemia. So this is basically what we found. Now he also has a codominant RCA which is sort of occluded. I'm not showing you that, but this is the only picture we have here of the diagnostic. All right, so we know that posterolateral jo hai, that's where the ischemia is. So, comment, any comment? David bhai, I'll start with you. We'll just go down this way.
Is this a running scene? Can we play it?
Acha, dobara play kijiye.
The technical team, please, can you play this again?
Can you play it again, please? ये slide दोबारा चला दीजिए.
That's great.
So I think there's a lot of disease in circumflex. It's a dominant sort of codominant sort of system. जो RCA है, you can see some of the collaterals going there, but it's not a very big RCA. So that ischemia is probably coming from the circumflex, right? The LED looks fine. There's plaque at the ostium of the circumflex. So again, we know that the issue is at the circumflex. Now, interestingly, the circumflex has two bifurcations. एक और आप कीजिएगा, please. एक bifurcation है which at the origin of the first big OM, और दूसरी bifurcation है at the separation of that second OM. आगे जो AV groove है वो तो है सो है. So anyway, so how do you approach this? Do you do upfront 2 stent strategy या 1 stent strategy? तो यहाँ पे मेरा ये था कि we should try to do provisional.
The
I'm sure you guys have the same experience. Treating a circumflex is almost always not that easy compared to the LED. When it comes to putting a lot of metal into that, when you're going to put your hardware into it, the experience is you're going to maneuver your stents and the balloons and all those, especially when it gets a larger size and the larger length. Putting down into the angulations, it's always a challenge. So keep this in mind. The LED is damn easy compared to most of the time compared to circumflex. So that is the one thing I always keep in mind every time I jump into any kind of bifurcation into the circumflex.
Actually, the posture of the upper OM is totally clear. So, इसलिए single strategy is the best for this one. Posture of the above OM is the clear, no disease free. So, single strategy is the better for this patient.
Absolutely. Excellent point. So कई बातें, एक तो ये है कि the ostium of the first branch is relatively clean. दूसरी बात है कि जो calcification इतनी नजर नहीं आ रही, probably होगी. But the main thing is कि जो plaque है, that's mostly toward eccentric, towards the atrial side of this branch. It's not towards the side branch. तो उसके इम्कानात जो हैं कि जी plaque shift होगा वो कम है. Now, having said that, again एक सवाल यहाँ पे आ जाता है कि when do you put a second wire or not? तो generally because हमें wires की उस तरह expense नहीं है, I like to put a second wire in just to be on the safe side. तो यहाँ पे फिर हमने एक second wire डाली, and then the first thing I did was just did angioplasty, high pressure angioplasty with a long non-compliant balloon, and the idea was to exactly prep the lesion and also see कि plaque shift कितना होगा या नहीं होगा. Okay, next slide please. Oh, वो तो मेरे पास है, sorry. So ये result है इस वक्त. दोबारा loop play कीजिएगा. Now, honestly, this looks really good to me. You know, बंदा कहता है कि अगर DCB होता, you would put a DCB in their mid circumflex and walked away. I think that, हाँ.
Balloon, we have different sizes, like starting from 2 to 3.5, and so a 2.5 set 20 or 30 will be perfect.
Yeah.
And we had a very good experience by looking in geographically later on. So they have a very good flow, and in fact, drug-coated balloon. Yes.
So in my biggest problem is in the US we don't have it, but this type of angiographic result after non-compliant balloon, I think most people would agree that this would be a nice one for drug-coated balloon. कि ना dissection हुई यहाँ पे, ना plaque shift हुआ यहाँ पे, TIMI3 flow आपकी preserved है. That was actually a 2.5 by 27 balloon, so 30 millimeter drug-coated balloon would have been perfect. Achha, Behral, we don't have that. Okay, so then we decided to go and stent. So one of the things I've been doing a lot, and those of you who kind of follow the WhatsApp group, I talk about this a lot, is a jailed semi-inflated balloon technique. So जब Bashir ने मुझे कहा था कि आप lecture दें, so that's what we wanted to specifically talk about. So I'm going to go over that. So this is the setup. So setup ये है कि we already have a balloon in the top branch. वो दो नुक्ते नजर आ रहे हैं. Yes.
So Salman is going to talk about this, putting a balloon in the side branch to protect it and use this balloon rather than the wire alone. So the number one question comes up, the ostium in this case was looking pretty healthy. So what were your thought process, or what were the cases you would select where you would put this balloon rather than the wire alone?
So
please.
For me personally, again, हमारी cost considerations थोड़ी different है, right? So in the US, I can afford to do this. Typically, I would do it for most branches जहाँ पे मुझे खदशा हो के pinch हो जाएगा. Because what I don't want to do is deal with the pinch carina. Now, in this one, probably we didn't have to do it, but I think if the plaque is less, we don't have to do it. We can walk away from this. But having
You're doing it on most of your cases.
But I'm doing it on most of my cases.
Got it, got
I'm also even doing it on the tight ones because जो है ना जो आपने कहा था कि upfront two stent strategy. If it's a small side branch, then I'm trying to avoid even putting that stent. You know, अगर आपका 3.5 millimeter की LED है और फिर 2.25 millimeter की diagonal है, if I can get away with this, I don't want to put that 2.25 millimeter का because even though Imran Bhai and the guys had excellent bifurcation session. इतने छोटा स्टेंट डाल के फिर उसमें से तारें गुजारना, it's very complicated, right? You want to make life simple, everyone's busy, you're busy, and you want to do something that's good for the patient. So what this allows me to do is A, protect the side branch, and B, maybe get away from having to do a two-stent strategy. And I do it for now. Again, if it's a major branch like the circumflex, here the PDA, PLB, तो वहाँ पे तो I typically prefer two-stent for different reasons. But this is more for OMs than diagonal branches. But excellent question.
If you do high pressure balloon with the wire inside the branch, so that can cut on.
यही तो है. This is it.
So that is the I think balloon is better in that sense than.
हाँ नहीं ये now I'm going to tell you all the secrets. I don't like to keep secrets. मैं आपको अपनी तमाम तो जो चीज़ सीखी मैं बताऊँगा. अच्छा, so first of all, कहा जाता था कि we put the wire in to protect the side branch. The wires don't protect side branches; they only mark them. ठीक है? So we've all seen this cases कि हमने wire डाली और pinch हो गई. Even though the wire is there, you just can't get back in. So wires do not protect side branches. Balloons do, however, protect side branches. दूसरी बात ये है कि a key element of this is not to do high pressure angioplasty. क्योंकि अगर side branch का pressure बहुत high हो, which is the original form of the jailed balloon technique, उसमें फिर होता है chances of actually dissecting the ostium. So इसमें the pressure has to be 4 atmospheres or less, and I'll show you that, and I'll tell you उसकी वजह क्या है, उसकी philosophy क्या है. Okay, but here's the setup. तो यहाँ पे आपको नजर आए 2 तारें हैं, जो ऊपर वाली तार है, उसमें you can see, I think you have the pointer, कि यहाँ पे there are 2 dots. जो पहला नुक्ता है, does this work? हाँ, अच्छा उस पे नजर ये रहा. So this is one dot, this is the other dot. So I've already advanced the balloon well into the top branch. और फिर ऊपर से फिर हमारा ये जो है ना sort of 32 or 38 millimeter stent आ रहा है. So now I'm positioning this. Now, one question is, Kiji, do you have to do a kissing branch inflation of the bifurcation? Sometimes you do, sometimes you don't. This situation में because the side branch was so open, I didn't have to do that. So एक तो ये बात होगी. So we've got the branch balloon parked there. You advance this, and then you can pull this balloon back. उसका फायदा ये है कि अगर किसी वजह से आपका स्टेंट नहीं जा रहा तो you can use this as an anchor balloon. So I always like to put the side branch balloon first.
Okay, so Salman, we have to please tell us also where you're going to put your balloons proximal
Absolutely.
angiography. That's the important, yes. Yeah.
Absolutely. सब कुछ आएगा. Okay. So we actually in our camera we have a high resolution हमारा system है, so we can go to high definition and high definition. Okay. So this is the setup यहाँ पे. So what I've done now is कि stent is in position. And I've actually pulled the balloon back. Now, this is one of my earlier cases कि जहाँ पे मेरी हमेशा ये होती थी कोशिश कि side branch का balloon जो है jail नहीं होना चाहिए. Because अगर jail हो गया तो निकालने में मसला होगा. But then there was some discussions on the group, and then जब literature पढ़ा तो लोगों ने कहा कि नहीं, you don't have to have the balloon extending out that much. So this is one of my earlier cases. फिर I saw a live case from China जहाँ पे उन्होंने they kept the balloon यहाँ से यहाँ तक. They actually kept it inside the stent. So they're saying, and someone asked them and they said, no, we don't have any problems with it sticking out. So now what I try and do is I keep the balloon about 2/3 of the way into the side branch and 1/3 into the main branch. That's my current philosophy. 2/3, 1/3, क्योंकि you need इतना balloon हो main branch में कि जब main branch का stent inflate हो तो वो contrast displace होके distally चला जाए. Because that's the whole philosophy of this is कि जो proximal में जब आपका pressure बढ़ता है in the main branch, that contrast gets displaced from this balloon and ends up in the lower part, and that's what protects the ostium. Because you have to have enough length in there. लोगों का different है. I think one of the original descriptions में उन्होंने तकरीबन आधा मिलीमीटर या 1.25 मिलीमीटर कम रखा हुआ था. I like to do it 1:1 because I'm doing low pressure. ठीक है ना? अब now this is 1:1 angiographically. I don't necessarily do IVUS every time. कई दफ़ा अगर हो कि जी is there dissection there, is there कितना plaque burden है, तो if I have IVUS I'll use that sizing, but typically it's visual. So in this case
semi-compliant balloon. Semi-compliant.
Semi-compliant. अच्छा दूसरी ये बात भी semi-compliant, because if it's a non-compliant balloon, तो non-compliant balloon में plastic क्योंकि ज़रा stiff होता है तो it doesn't compress as much as a semi-compliant balloon. ये भी बात है. So let's summarize that. बहुत good points. So number one, कि side branch balloon 2/3 side branch में होगा, 1/3 main branch में होगा. उसका diameter जो है angiographically side branch का होगा 1:1, और दूसरा ये कि semi compliant balloon आपने रखना है. That's sort of how I do it.
And you're using upfront 7 French guider, or are you doing it with the 6 French guider?
6 French.
Okay.
I don't know what's microphone or not, but okay, we're doing 6
Well,
French.
again, no, here's the thing now, because I can compare believe me, and I'm not making it up, because I have the experience of the equipment using in the States as well in Pakistan. There a lot of time we are having difficulties putting in a 6 French guider when we're using a balloon and a stand. I get stuck.
हाँ,
It
so-
does happen.
So it depends on the brand. उसमें मेरा brand I'd prefer Medtronic. उसका inner looping ज़्यादा है. Cordis वगैरह में नहीं होता. Cordis की guides में आप नहीं डाल सकते. I don't know. I'm sure you have other guides
Sorry.
also.
Regarding guides,
So the same experience as ours. Our guide very hardly accommodates a balloon and a stent. So a
Sorry.
6 French guide. So that's why we also
But-
educate a 7 French.
for
But-
that, I will also comment regarding guide. So our experience is totally different regarding the guide. We use EBU, we use Pandra. This is Netherlands or something. We use Chinese guides, and we also use this Cordis. All of these 6 French accommodate trio, stent, and even 2.5 or 2.75 or even 3O NCs from Sapphire, or from any good brand like Micros. This is a Chinese brand, but it's excellent as well. From Ryujin, this is Trumo, this is excellent. So the most important things are that you should have a good guide sport. If it's a XB, it's a 3 or 3.5, that's important. Never you do in the jail or something. The second thing is you take the stent first and follow with the new balloon. So it will always go until unless your wire are intermingled or something. So this is what our experience is, and luckily that is different from the others, but we never have any difficulty in that. We only have difficulty in the left main sometimes if we have a stent in the side branch and we want to take an NC of 4.5 or something. Even if it's new, it will always go, almost always go.
I think that's a great point. Again, उसमें मैं ये कहूँगा कि एक तो कि the technique doesn't depend on the guide. Any guide that will accommodate both the stent and the balloon, but your points are well made. मेरा भी experience है. Again, the difference is कि हम लोग in our economy we can always open up a new balloon. Like in Pakistan, if you're using the one balloon, right?
Yeah,
So cost-wise,
definitely.
I think 7 French का idea मुझे अच्छा लगा है, because what you can then do is
So
you can
if
treat
we
main
want,
branch.
if we want to, sorry to cut, comment regarding this used balloon. So if you want to take a 2.5 or even 3O NC, usually it always works if you want to place a used balloon parallel to a stent. You have always to reprofile it. If you reprofile it in its profiler, so again it will go. Sometimes it does not go, but mostly
Okay.
it goes.
Reprofile कर दिया, or what you can do is you can advance it. You can use it first time in the main branch, then use it for the side branch. ठीक है ना? और तीसरी बात ये है कि reprofile कर दिया. तीसरी बात ये है कि you can then use it as an anchor. वो balloon पहले डाल दिया, anchor करके then get the stent across. Well, कई दफा it's snug, but if you can get past that monorail part, then it starts
So if
moving
your
again.
stent is a good one, trackable, so
Correct,
that's an
exactly.
excellent trick to anchor.
You have a comment?
Dr. Ahmed Khan from Australia.
हाँ जी.
I've learned this technique from you, and I've done a lot of cases. So just the length of the balloon, I had problem initially when I did my first or second case. A 8 millimeter length balloon was stuck behind the stent.
8
And
millimeters.
I just put just the ostium and a bit in the left, in the main. When I did my first case after learning from master class. So now I'm using 10 to 12 millimeter. What's your usual practice for
So-
the length of the balloon?
हाँ, so that's a great point. अच्छा, कि कम से कम balloon length कितनी होनी चाहिए? I would say at least 15, 12 to 15. उसकी वजह ये है कि the whole reason is you have to have enough length कि contrast displace हो सके. 8 is a little too short. ठीक है ना? 8 is too short. एक तो you don't get the जो semi-inflated जो effect है वो नहीं होता. दूसरी बात ये है कि if you have the proximal dot inside and now you put a stent, तो जो opening है ना जो balloon की, तो where the contrast comes out is towards the top. अगर आप कभी balloon को deflate होते देखें तो हमेशा वो tip से deflate होता है पीछे की तरफ. And if that area gets kinked behind calcium, तो फिर तो आपका balloon नीचे नहीं आएगा. And in fact, we've had that issues in peripheral cases जहाँ पे the balloon is difficulty coming down and it gets stuck. And that stuck balloon inflated behind a stent is very difficult to deal with. So again, use a long enough balloon. 2/3 should be in the side branch, 1/3 in the main branch, come 15. So that means 5 in the main branch, 10 in the side branch. Okay, in the interest of time, I'm going to move forward. This is more common than I expected, but this is good. This is wonderful. Acha. So this is the setup now. Like I said, this is one of my earlier cases. If I had to do this today, probably my side branch balloon would not be that long. Next step ये है कि your side balloon has to go up first. Okay, this has to go up first. उसकी वजह ये है कि because once the main branch stent starts coming up, it is then going to displace the contrast, right? So ये आपका हो गया. Next you go up with the stent, और ये आपका stent डल गया. Now, something interesting is happening यहाँ पे. Look at the carina के क्या हो. So carina is getting pinched. This is that so-called plaque shift. देखिए ना जब कहते हैं कि plaque shift क्या है. So plaque shift is not so much plaque shift, it's actually a carina shift. It's a distortion of the carina. और जो IVS studies में अगर देखा गया है तो what is a round lumen of the side branch becomes like an ovoid or kidney bean shaped lumen. उसकी वजह ये है कि because the whole carina shifts. What that inflated balloon is doing is limiting how much it shifts. Okay? And I'll come back to this point, but ये आपको दिखाना था कि this is the mechanism by which this works. जो pressure है ऊपर वाले balloon में, जो side branch balloon में, it's about 4 atmospheres. नीचे वाले में, that's a full 16 pressures, 16, 18. I usually deploy at high pressure.
Okay. Can I just make a quick comment here? So before just one quick comment. When you dilate the balloon of the side branch, I'm sure you will agree with that. Please make sure your stent in the main artery is well positioned. Because when we have a balloon inflated, okay, I know we're not inflating it to high pressure, but I have seen at times your flow to the distal vessel is the main vessel is limited, and you cannot see where your main stent is. Let's make sure your stent is already distally well placed.
Right, right. Okay. So after dekha tha, I had the side branch balloon, I put the main branch stent in, then I pulled the side branch balloon. You're absolutely right. दूसरी बात इसमें ये बताई थी कि why doesn't the balloon get stuck? I किसी ने पूछा नहीं, but I think that was the implication कि अगर आपका stent पीछे है. तो जो endoscopic videos, and again I think Imran bhai showed some of those cases. अगर endoscopic videos में देखें, the main branch का जो हिस्सा है, before the proximal to the bifurcation, it's always a little wider. कुदरती तौर पे आपके दरख्त को देखने की भी any branching in nature, the main branch is wider than the side branches, right? तो उस हिस्से में हमेशा इतना gap होता है कि आप balloon को वापस खींच सकें. और अगर किसी वजह से ना खींच सकें, you can always dilate the balloon and make some room for yourself, लेकिन उसकी कभी नौबत नहीं आई. So the whole reason this works is, and the balloon does not get trapped, is कि unless you have really eccentric nodular calcium, most of the time इतनी जगह होती है, even when the main branch stent is being deployed, कि side से balloon निकलता है.
Okay, Salman, with the same thing now, what pressure are you going to inflate your stent at the time? Are you going to go, when the balloon is inflated in the side branch, when you're going to deploy your stent, are you going to take it nominal first, or you're going to take it a full, the maximum?
Great point. So I don't think I've done a nominal stent deployment in decades because I was trained that way. Like, usually I do about 16 to 20 atmospheres. I'll go high pressure.
So you are okay to go ahead with the initially within first inflation of the stent, you okay to go with the maximum pressure?
Not maybe maximum, because maximum for me is about 24, but I'll go to
well,
about
I mean,
16.
the
high pressure, above nominal, absolutely.
The reason I asked this question, I'm sure you guys are familiar with that, because initially when the people start doing this, I think in the China or wherever in States, people start doing this stent in a nominal pressure. And then pulling the balloon back and then going back, making again. So your experience is we're okay to go to the pressure. Got it.
Okay.
Thank you.
So in the interest of time, I'm going to move on because I could talk about hours for this. Achha, next step ye hai, you deflate the balloon, main branch balloon, then you deflate the side branch balloon, or perhaps side branch balloon nikal le. Now, what's interesting is the main branch balloon has not moved, right? So side branch goes up, stent goes up at supernominal pressure, stent balloon comes down, side branch balloon comes down, side branch balloon comes out, and then you go back up on main branch to much higher pressure. Okay? This is the second main branch. So this is not a dot or a pot. This is still the stent balloon catheter जो कि आपने high pressure में डाला है. Okay? And then you go ahead and then you do the pot. ठीक है ना? अब उसमें controversy ये है, सवाल आता है कि जी pot करने से पहले should you take the side branch wire out or not? तो उसमें मेरी philosophy है कि we didn't store it here, but you do a fluoro test. अगर आप fluoroscopy में करते हैं and you see that the side branch flow is not compromised, then you can safely take the wire out and then do a pot. Pot हो गया, and then this is your final result. You'll see it right there. ठीक है? So the carina is actually preserved. ठीक है? And this is a nice case. लेकिन the reason I wanted to show you this is कि अगर आप देखें तो दूसरी जो bifurcation थी, वहाँ पे कराना pinch हो गया. Now there's a hazy spot there जो पहले नहीं था. So this case I chose it because not only is it a good demonstration of how to do the jailed semi-inflated balloon technique, it also shows you कि what happens to the carina अगर कि वो branch भी उतनी ही दिखने में खुली थी या patent थी शुरू में, लेकिन आप देख लें, and hey, that's a nice spot. Just don't play it. This is a good spot. नहीं अब play ना कीजिएगा, अच्छा चले खैर अब रुकने दीजिएगा उसे, but don't play it again. You can see that this anatomically looks very nice और यहाँ पे देखें थोड़ा सा कराना shift हुआ है. There's some extreme cases again हमने WhatsApp में कुछ cases में देखा है कि जहाँ पे side branch काफी हद तक pinch हो जाती है. So again I think the big advantage of this technique is कि आपकी जो है ना, now this branch granted is not that big enough कि इसमें भी वो किया जाता, but this branch was because यहाँ पे this is what supplies the posterior papillary muscle for mitral regurgitation. So जिन लोगों को shortness of breath होती है from these circumflex CTOs, it's because they get ischemic MR, and this is the branch that's responsible. So that's why this is so important.
So Salman, with the same token, another question comes up here. When you are doing your part, is it mandatory? I know you did not do it. Is it mandatory to have the rewire of the branch, or just okay with the fluoro check and that your part is, the balloon for the part is proximal to that?
That's a good point. What I like to do is कि I like to first of all check the flow. Side branch balloon आपने निकाल दिया, आपने second inflation कर दी stent balloon की, then you check the flow. If the flow is good, then you take its side branch out. Take a side branch wire out. Then the potting balloon, I put it कि जो उसका distal dot है, marker है, that's actually in the carina, in the zone of confluence. वो जो तिकोनी बनती है, the zone of confluence उसमें होना चाहिए. That's what I do. I don't try and go too far because then I can shift the carina again. Because the whole idea was not to shift the carina. If you go into the main branch, you're going to shift the carina again.
Guys,
just a
please
short
feel
question,
free to ask the
Salman.
question. This is the time here.
Just a short question. कि अब हमारा main theme of jailed balloon is के side branch compromise now. अब हमने जब pull out कर लिया side branch balloon, then we again inflated the stent at a higher pressure without the balloon the side branch. Then the risk of side branch compromise again is much more high.
That's a great point.
But the rationale to put a balloon first and then do
Exactly.
this maneuver.
So that's a great point. अच्छा, maximum displacement of the carina उस वक्त होती है जब stent deploy हो रहा होता है, right? एक जो stent deploy हो जाए तो वो एक stent का exoskeleton बन गया है. जब दोबारा करते हैं तो it will not shift the carina that much. You're absolutely. That's a great point. कि अगर आपने पहले तो protect किया था, now if you do it again, now if however you do dot, ठीक है ना कि you distal to the carina and then you do the dot without the balloon, that can still shift it. क्योंकि वो dot may preferentially it will get the distal part of the stent up, but you're absolutely right because lamba stent as long as it goes across the ostium shouldn't displace the carina.
The same thing that Salman just said. I was saying that if the stent is not optimized now, you have to NC it, as he said, dot. At that point, then you can again shift the carina again. I think at that point, you may need to rewire the side branch before that.
Absolutely.
Can I just say a word about it? So, one of the technique is this gel balloon stenting technique, and another is to treat your side whistle with a FKBI. That is, suppose you optimize and you have lost, or there is a carina shift of your side branch. So what you do, just take that semi-compliant balloon and do a kiss, and that's it.
So you're absolutely right, but I think the point was कि अगर आपने dot करना ही है, if you're going to use a non-compliant balloon, then there is a risk that carina will shift the second time round. So then pass the second wire, and maybe you can do that. In fact, we've done a dot with having a semi-inflated balloon through the stent struts. But you're absolutely right. Acha, so this is the final angiogram. ये शुरू में था, and this is our final. Just to show the comparison. I'm sorry, loops चल रही है इसमें. But anyways, this is summary. Okay, so this is a technique. अगर किसी तस्वीरें, this is the one you need to take a picture of, and this is the one you need to put in your cath lab. Okay, this is how you do it. So number one, semi-inflation, side branch inflation at optimal pressure. Number one, ठीक है? उसके बाद you go up, you come down, just to make sure कि side branch जो है, that's open and all that stuff. KBI, high pressure in the main branch, low pressure in the side branch. उसके बाद you remove the main branch balloon, position the MB stent. Now, पहले दो steps हमने इसलिए नहीं किए थे because the side branch was already looking good and we did not have to do KBI. This is optional. Step number 3, आपने position stent किया, and then you can use a side branch balloon to anchor. You deploy the main branch stent at nominal pressure with SB up at low pressure. Number 5 is important. This should have been in red. Side branch balloon goes up first and it comes down last. ठीक है, ये बहुत ज़रूरी है. Angio to confirm side branch patency. remove side branch balloon and perform second MB inflation at high pressure, as long as it's the same balloon. अगर आपने dot या pot किया तो make sure you don't cause carina shift. अगर करना है तो you can do it, but just advance the wire. Pot or dot if needed. And post angio, consider KBI if the side branch has 70%. वही आपकी बात कि if you do end up with a carina shift, इतना नहीं होगा कि वो pinch हो जाए. It will just get distortion of the cell struts होगी. You can then go ahead and rewire it and then open that up again.
Okay,
That's it.
I think. Well, I wish we had more time. We're getting from the admin that our time is up. I know Salman had a lot of other cases, so do we. And
Actually, so दूसरे case में एक और बात थी which इसमें नहीं है, but let me add number 10 उसमें. If you do have to rescue it, ठीक है, अगर आपने जो आपने criteria बताया था कि जी एक ST elevation हो रहा है या chest pain शुरू हो जाता है या flow compromise हो जाता है side branch में despite KBI, फिर you can actually rescue this by either doing a tap or you can make it a clot. वो दोनों option आपके पास हैं. That all depends on the side branch की anatomy क्या है, angulation, bifurcation क्या है. But बहरहाल, my experience is I was a skeptic. I think this is a good technique. I think it's a technique that will serve you well. You have to do it to get good at it. But you will find a lot of those cases which you thought initially were going to be 2 stent can quite satisfactorily be done with 1 stent and everyone wins. Thank you.
okay, I know that the next session, Dr. Tayyab is going to teach us the collard technique as well, and we will learn over there. Thank you very much, and thank you, Salman and Dr.
Pertaining to this, do you do part and dots in your practice? Like how much you expand your stent post-dilatation?
So the very good question. I think dot I probably do around maybe 40 to 50%, maybe 40%. Pot I do about 80% or so. Because pot you almost always have to do. In fact, the bigger the main branch, the more likely I am to pot. In left mains, pot is 100%.
Okay, I just have a general question for the whole audience, and that's not related to our talk here. What is your experience of pulling the wire, jailed wire, after you inflate the stent from the side branch? Did you guys ever got stuck with pulling the wire out? Your experience of pulling the wire, the jailed wire, with pulling out. Have you guys ever experienced the wire got stuck in? Are you talking about the practice in Pakistan or across the other? Yes. So Salman, this is another thing. And I can tell you that goes again with the quality of the stuff. I have seen actually the more issue with the wire getting stuck in here, or when you try to come out, you feel like there is going to stuck it. And I think that's all because of the material. Believe me, the same Shen wire or any other blue wire, any other wire which we used in the States is completely different here. So that's kind of it. So people have an experience with that, yes.
Really bulkier, it's got stuck always most of the time, and the same is with the wires. They have a different quality, honestly.
And he said that I couldn't believe it, but maybe it's a different quality. But for me, the wire doesn't get stuck unless the wire is broken. अगर wire का core टूटा हुआ है, because आपने दोबारा wire use की या stride switch में जाते हुए, that's more likely to be. Okay, anyway, thank you very much, everyone, and thank you for making it interactive. Thank you.
Challenge, thank